So now let's move on to look at neonatal assessment and resuscitation. So we're still going to be following our standard precautions. By now you might need to change your gloves and put on a new set before handling that newborn. They should begin breathing spontaneously within 15 to 30 seconds after birth. Generally, you'll hear that first cry after you start to suction the airway a few times and get all of that mucus out. The heart rate should be 120 beats per minute or higher. And if you think back to talking about CPR, we'll remember that if the heart rate is less than 60, we'll need to initiate compressions. If you do not observe these responses, you're going to start to stimulate the baby. And so you can do that by tapping or flicking the soles of the feet or rubbing the back. You want to do this vigorously, and that could be with a towel. So we're warming, drying, stimulating. Some newborns may require other forms of stimulation, like positioning of the airway, suctioning, or other tactile stimulation. So resuscitation for newborns who are not breathing, we want to assess and support their temperature. So warm and dry, airway, position and suction, breathing. We can stimulate to cry. So again, suctioning with that bulb syringe out of the OB kit. If we need to use a BVM and ventilate for the patient, we would do that here. And for the newborn patient, you would be ventilating about every 3 seconds. And then we're also looking at circulation, so heart rate and skin color. So drying and warming, clearing the airway with the bulb syringe, stimulating, ventilating, and if no pulse or if the pulse is less than 60 seconds after 30 seconds of ventilation, then we would want to start CPR. We want to position the newborn on their back with the head down and the neck slightly extended, so in a sniffing position when we are suctioning using that bulb syringe. Looking at some other additional resuscitation efforts, we want to observe the newborn for any spontaneous respirations, skin color, and movement of their extremities. So we're going to get that Apgar score that we talked about. We'll get to that in just a second. And we want to evaluate the heart rate at the base of the umbilical cord. So if that's might still be pulsating, or at the brachial artery, or by listening to their chest with a stethoscope to listen for their heart tones. So again, if the heart rate is more than 100 beats per minute, that's normal. So keep the baby warm, transport, and assess. If it's between 60 and 100 beats per minute, we might need to begin ventilations and reassess every 90 seconds. If it's fewer than 60 beats per minute, we want to begin chest compressions. We're going to need ALS and, again, ventilating with the BVM. If chest compressions are required, we would fall back to those AHA guidelines of if you are by yourself, you would utilize the 2-finger technique going at 30 to 2. If you are 2 people or more, you would use the thumb encircling technique, and you would do a ratio of 15 to 2. I know this says 3 to 1. That's an old ratio, so it's 15 to 2. And these are just the demonstrations there of the thumb encircling technique, just to remind you where to place your fingers at. If you see any meconium in the amniotic fluid and the newborn is not breathing, we want to quickly suction the newborn's mouth and then the nose each time before providing those ventilations. And if you've already called for ALS, they might actually deep suction the patient with a meconium aspirator tool. So just something to consider, but they're definitely going to need a lot more suction if you see the presence of that meconium, or as we mentioned before, that bowel movement that the baby actually had while it was in utero, and that might be because it was in distress, or it could be because the baby is past 40 weeks. Those are 2 times when we generally see the meconium. So looking at the Apgar score, which we mentioned previously, this is the standard scoring system used to assess the status of a newborn, and it assigns a number value to 5 areas, so much like a GCS. And it looks at appearance, pulse, grimace or irritability, activity, and respirations, right? Those are the things that it's going to be looking at here. And so the total of those 5 numbers is going to be your total score, and you get those Apgar scores at 1 minute and at 5 minutes. So very important. You'll see some test questions that ask about that immediately, 1 minute after birth, and then at 5 minutes. So you'll give a score of 0 to 2 for each one of these. So the highest Apgar score is 10, and obviously the lowest is 0. So if the baby is completely pink, that would be a 2. Generally, what's pretty normal at the 1 minute and maybe even the 5 minute mark, depending on the baby, is when the body is pink, the core is pink, but the hands and feet have that bluish tint or are cyanotic, and that's okay. But the worst here would be if they are completely blue or pale. Obviously, we talked about the heart rate normal being over 100 beats per minute. Grimace or irritability, the newborn should cry and try to move their foot away from a finger snapped against the sole of their foot, or even a weak cry in response to stimulus is better than nothing. If the newborn resists attempts to straighten their hips and knees, so you've all seen newborn babies, how they're all tightly rolled up in a ball. If you pull their legs straight, they should fight back against that and immediately resume the position they had. If they do not resist that, or if they have no muscle tone, that's a bad finding. And then again, the baby should be breathing rapidly. Newborns can breathe up to 60 times per minute, so rapid respirations are normal. Slower respirations, you would give that a 1. If obviously we would need to intervene if we didn't feel that was adequate, and then absent would be 0. So we would calculate that Apgar score and look for any need for stimulation. If they are breathing well, go ahead and assess the pulse. We want to assess the oxygenation via a pulse oximeter. If you have the ability to use a pediatric pulse oximeter, where it's kind of that little sticker that will stick to the toe. And then we can request a second unit, as we mentioned before. If the newborn is in distress and needs additional resuscitation, we want to put as much focus on as we can on the baby, but not forget about the mom. So we want to make sure that we're getting that second unit so that they can both get the care that they need if necessary. In the situation where you need a BVM, make sure you are using a newborn BVM and mask that fits the baby's face adequately. And now we're going to move into talking about some abnormal deliveries. So this is a breech delivery. As we said, most infants are born head first, but occasionally the butt is delivered first, and this is called a breech presentation. And so a full breech or a frank breech, which is what we see here, that can be delivered in the field. It's going to be extremely painful and difficult for the mom, but it can be done. So if you see that butt instead of the head, that baby can still be delivered in the field. So these breech deliveries usually take longer, so you might have time to transport the pregnant woman to the hospital, but if the butt has passed through the vagina, then the delivery has already begun and you will need to go ahead and deliver that baby at home. Preparing for the breech delivery is the same as for normal childbirth, but you're going to let the butt and legs deliver spontaneously and support them with your hands. The head is usually face down here and should be allowed to deliver spontaneously again on its own, but the difference here is that you want to make a V with your gloved fingers and position them inside of the vagina to keep the walls from compressing the airway. So this is only one of 2 times that you are going to put your fingers into the vagina, and it's very important that you put this in there and just kind of make a V around the baby's mouth and nose. And it's less about supporting the face and more about spreading the walls of the vagina so that they do not compress down around the neck and the airway. So create that V pocket for them to be able to breathe. Other presentation complications, this is an arm or a leg or a foot. So this is a limb presentation, and it absolutely cannot be delivered in the field. I mean, if you're just looking at this picture here, you know that there is no good way for the remainder of that baby to come out. So anytime that there is a limb presentation, it cannot be delivered in the field. This needs to have rapid transport, and that's the best that you can do for this mom. If the limb is protruding, you can cover it with a sterile towel, but never try to push it in or pull on it at all. The best way to transport this patient, the mom, is going to be if you have her on her hands and knees with her hips elevated, or you can have her lying supine with her hips elevated, and this is going to just try to take as much pressure off of that limb as possible and also kind of help reduce the urge for her to need to push. Same way that we could potentially transport if this was a cord presentation, and that's called a prolapsed cord. So a prolapse on the umbilical cord, again, cannot be delivered in the in the field. It needs to be delivered at the hospital by cesarean section. If you take a look at this baby's head, how it's coming down and compressing the cord, that should make sense to you why. It's the same reason why you can't deliver the placenta first. Compression of that cord would cut off the baby's oxygen supply, and it again could take minutes, it could take over an hour for that baby to deliver. And so we can't go that long without oxygen, so we need to make sure that we are not delivering this in the field, because that's going to cut off the baby's oxygen. So this is the other time where you would insert your gloved hand into the vagina. So you want to try to keep the fetus's head from compressing the cord. So inserting your gloved hand into the vagina and gently pushing the fetus's head away. Now you don't want to push too hard. You don't want to push down into the fontanelles or anything like that, but just gently trying to guide their head away from the cord. And then same transport that I said, hands and knees with the hips elevated is going to be your best option to keep the pressure off of this cord, and rapid transport to an appropriate facility. So looking at a couple of other things here, spina bifida. This is a developmental defect in which a portion of the spinal cord or the meninges may protrude outside of the vertebrae. Generally, the parents will know that this is the case and that the baby was already diagnosed with this in utero, but sometimes they don't see it on ultrasound, so it might be a surprise. We want to cover the open area of the spinal cord with a sterile, moist dressing, and the biggest thing here is maintenance of body temperature. So when you put those moist dressings on, then turn around and make sure that you are in turn really wrapping that baby very tightly in a lot of blankets, keeping it as warm as possible for transport. If this is multiple gestation, so twins is really fairly common once in every 30 births. Twin babies are smaller than single fetuses, and their delivery is typically not difficult because of that, because they're a little smaller. Generally, within 10 minutes after the first birth, contractions will begin again, and the birth process will repeat itself. So same process, your procedure is the same. You just want to make sure that you record the time of birth separately, and that you try to tell them apart, especially if they are both boys or both girls, that you use some kind of marking system, whether that is writing a little sticky note or a piece of tape, or write on their blanket, baby A, baby B, so that you don't mix them up. Twins may be so small that they look premature, but remember, they're not. The average gestation, what's considered full term for twins, is actually 36 weeks. So premature birth is considered any baby born before 36 weeks or who weighs less than 5 pounds, unless it's twins, because that's pretty normal for twins. But if it's a single fetus that is born before 36 weeks or who weighs less than 5 pounds, they are considered premature. A premature newborn is smaller and thinner, and the head looks proportionally larger. This is a premature newborn, and this is kind of an old picture, but a premature newborn in comparison to a typical size newborn. They might need some special care to survive. They might need to spend some time in a NICU or a neonatal intensive care unit. Temperature management is huge for them. So postterm pregnancy is any pregnancy lasting longer than 42 weeks. The average gestation is 40 weeks, and that starts counting from the first day of the woman's last menstrual cycle is actually where you start counting the pregnancy from. So if it's longer than 42 weeks, that's considered postterm. Now, a lot of times, just because of the dangers of postterm pregnancy, OBs generally don't like women to go that long. They will start to consider induction once you get past that 40 full-term week mark. But for some, they prefer all natural, so they'll wait until the baby is ready. Sometimes the baby can actually be quite large here, maybe weighing more than 10 pounds, and this can lead to problems with the woman and the fetus, again, with that meconium as well is one of those risks. There's an increased chance of injury to the fetus just due to the size, the increased likelihood of cesarean section, and the woman may be more at risk for perineal tears and also infection. Post-term newborns have increased risk of meconium aspirations, infection, and also being stillborn. So like I said, there's a lot of risk at going this long, so that's why a lot of OBs try to avoid that. With that being said, one of those things is fetal demise. So the onset of labor may be premature, but labor will progress normally in most cases. If an intrauterine infection caused the demise, then you might note a foul odor. You should not attempt to resuscitate an obviously dead neonate. So this is probably one of those times where this will be one of the toughest moments of your career if you were to encounter this, especially if the baby is full term. So usually this is detected in an OB's office, like if the mom has not felt the baby move for a certain amount of time and she goes into the office or into the hospital and they're able to detect that there is no longer a fetal heartbeat, but she may go into labor and it may be that that this occurs. So things that we're looking for here for obviously dead would be if the baby is completely limp, if it's gray, if the skin is sloughing off. I don't mean that the baby is just limp and blue and requires some resuscitation, but again, a foul odor, just obviously dead. Those are times when we should not attempt to resuscitate. And the biggest thing from here is going to be emotional support for the mom. If you have to deliver without your sterile supplies, you at least need to have some type of eye protection, gloves, and a mask, and then carry out the delivery as if the sterile supplies were available. Try to use some freshly laundered sheets and towels. Wipe the inside of the newborn's mouth with your finger. Do not cut or clamp the umbilical cord. Basically, what you would do is just keep the newborn at the same level of the placenta. So before it delivers, keep the baby at the level of the vagina. After delivery of the placenta, you could wrap it in a clean towel and lay it at the same level of the baby. So if the mom's holding the baby, put the placenta up there too and transport them. If bleeding continues after the delivery of the placenta, like we said, we want to do that fundal massage to the uterus. So if it continues and it's not stopping after that, check your technique and your hand placement, and I will try to post a video of an appropriate fundal massage as well. We can also cover the vagina with a sterile pad to help absorb some of that blood if it continues, but remember, we never want to stick anything in there. So continue to monitor the patient and treat for signs of shock if you suspect that a lot of blood has been lost. Postpartum patients are also at an increased risk of an embolism. So most commonly, this is a pulmonary embolism. This results from a clot that travels through the bloodstream and becomes lodged into the pulmonary circulation. So we want to consider this if she complains of a sudden difficulty breathing or shortness of breath or chest pain that came out of nowhere. Those are things that we want to start to consider. Maybe this was an embolism. But that's going to end this. I know this was a really long chapter, so thank you guys for hanging out with me. If you made it this far, hopefully you did. If you have any questions about this, please let me know. I've attached a couple of videos regarding the delivery in the field and some delivery skills, and I'm, like I said, going to try to post a fundal massage as well. So if you guys have any questions about any of this material, please feel free to reach out and let me know.